So I want to welcome everybody here today. We're carrying on with National Kidney Month and with our NUGoKidney Innovation Symposium. And I am absolutely delighted today to welcome a colleague and a friend, Dr. Keisha Gibson, who is Associate Professor of Medicine and Pediatrics and Chief of Pediatric Nephrology at the University of North Carolina in Chapel Hill, where she also serves as the inaugural Vice Chair of Diversity and Inclusion for the Department of Medicine. Now, Dr. Gibson received her MD and Masters of Health degree in epidemiology from UNC at Chapel Hill, and then did her residency in pediatrics at the Medical University of South Carolina in Charleston, and returned back home to UNC Chapel Hill to do her fellowship, where she has stayed on and has had an absolutely spectacular career. She's widely recognized as an expert in glomerular diseases and has led a number of working groups for KDIGO at Kidney Health Initiative, and she's widely published in all of the top kidney journals. Her research in epidemiology has focused on ethnic and socioeconomic disparities, and I think we're in for a real treat today to hear her talk on race and nephrology. She is a co-investigator in a number of large studies that I know a number of people here at Northwestern are involved with as well. The Nephrotic Syndrome Network Study, or Neptune, as well as the CURE-GN study. And she's received many, many honors. I know she's a phenomenal teacher. She's received lots of teaching awards. In 2018, the Hyman Battle Distinguished Excellence in Teaching Award, and in 2019, the Foundation Phase Excellence in Teaching Award. She's currently serving as nephrology counselor for the Society of Pediatric Research, and where I've had the privilege of getting to know Dr. Gibson very well over the past couple of years, she serves as the treasurer of the American Society of Nephrology. And for those of you who don't know, that's a huge job, and she approves all the new programs. It was Dr. Gibson who approved the loan mitigation for trainees traditionally underrepresented in medicine, and that's really a spectacular advance. And also throughout the pandemic, she kept things afloat. So really amazing. And she's also served in many other roles at the American Society of Nephrology as on the program committee as TREC's mentor. She was one of the founding members of the Diversity, Equity, and Inclusion Committee. She's currently the council liaison to workforce and training, and leading our efforts with the ABIM and ACGME to make sure that nephrology is well represented and the future is bright. And although I wasn't in the room where it happened, I know she testified or presented to the Assistant Secretary of HHS, and I think pretty much single-handedly got Rachel L. Levine on board with nephrology, and she's currently serving on the steering committee of Kidney X. So with that, Dr. Gibson, you're a wonderful champion and leader in our kidney community, and are just so delighted that you're here with us today. We're very much looking forward to your presentation.
Well, thank you. So good afternoon, everyone. I first want to say thank you for the invitation to speak today. It was a gracious invitation, a gracious introduction from my good friend, Dr. Quagan. We find ourselves in a very exciting part of the year. March is, not often known as a very exciting month, but it truly is. We're all focused on kidney health this month. We just celebrated World Kidney Day last week. We're in the midst of March Madness. We have Neph Madness that's currently ongoing. If you have not checked it out on Twitter, you are missing out. So please jump in the mix and get into party there. But overall, I'm just quite happy to be here to open what I hope will be a great discussion around race and nephrology. So by the end of this talk, I hope to leave you all convinced that, one, examining race-based outcomes in kidney disease through a biologic lens alone is myopic. That two, we must consider the impact of structural racism in kidney disease outcome disparities. And then I hope to leave you with some good news, that there are concrete actions our kidney community can take and has already started to take to combat the social inequities that we see driving CKD outcomes. These are my disclosures, but none will impact today's talk. So when we're looking at certain determinants in our patient's health, we like to place them in buckets. Some of these buckets we easily can ascribe to being more biologic, like age, sex, comorbidities like hypertension and diabetes, other factors like socioeconomic status, healthcare access, things that go into our built neighborhood and environment, all squarely fitting in non-biologic determinants. To focus on a few of these things, adiposity or obesity, we recognize has many downstream effects on insulin resistance, factors impacting hypertension, inflammation, oxidative stress, all directly and indirectly impacting CKD outcomes. You've invited a pediatrician, and so you will get some pediatric data today. Sex disparities among children with end-stage kidney disease have certainly been described. The US RDS, for those that may not be familiar, is a mandatory reporting system for all patients initiating kidney replacement therapy in the US for outcomes tracking. In this analysis, about 14,000 children were analyzed, and we found that the hazard ratio for death was much higher for girls than boys at 1.36. Even after adjusting these models for as a time-dependent covariate, transplantation as a time-dependent covariate, girls maintained a 28% higher risk of death over boys. Girls were also less likely to receive a kidney transplant as their initial form of renal replacement therapy than boys, even in analyses that treated death as a competing risk. So there were a few reasons postulated for these differences, and they included things like the fact that boys are more likely to have urologic abnormalities with high urine output failure, whereas girls are more likely to have glomerular diseases like lupus and HSP that may be associated with more systemic inflammation and subsequent cardiovascular disease. These data on incident end-stage kidney disease trends from the US RDS highlight a pattern that matches what many of us see in our dialysis unit, where Black Americans are 4 times as likely as white Americans to develop end-stage kidney disease. And although the gap overall appears to be closing, American Indians and Asian Americans still have twice as likely and 50% as likely, respectively, risk for developing end-stage kidney disease compared to white patients. But when we look at these data, what are we really seeing? Are these race-based differences driven by biologic differences, or is there something much more? So for those that regard race as a purely biologic construct, the basis for the disparate outcomes observed are due to genetic differences between ethnic groups. Now, almost every one of you listening to this knows that this is not correct. The problem with this thinking is that race is not a biologic construct, but in fact a social construct. An ethnic group is not defined by physical or anthropomorphic features, which is now a discredited definition for race, but rather describes a group of individuals with common geography, history, language, culture, and values. To further highlight some of the challenges in how we think about race, I'm going to play this short segment from Professor Dorothy Roberts, who is a social justice advocate and lawyer from UPenn. I apologize, the video is just taking a minute to come up.
15 years ago, I volunteered to participate in a research study that involved a genetic test. When I arrived at the clinic to be tested, I was handed a questionnaire. One of the very first questions asked me to check a box for my race: white, Black, Asian, or Native American. I wasn't quite sure how to answer the question. Was it aimed at measuring the diversity of research participants' social backgrounds? In that case, I would answer with my social identity and check the box for Black. But what if the researchers were interested in investigating some association between ancestry and the risk for certain genetic traits. In that case, wouldn't they want to know something about my ancestry, which is just as much European as African? And how could they make scientific findings about my genes if I put down my social identity as a Black woman? After all, I consider myself a Black woman with a white father rather than a white woman with a Black mother entirely for social reasons. Which racial identity I check has nothing to do with my genes. Well, despite the obvious importance of this question to the study's scientific validity, I was told, don't worry about it, just put down however you identify yourself. So I checked Black, but I had no confidence in the results of a study that treated a critical variable so unscientifically. That personal experience with the use of race in genetic testing got me thinking, where else in medicine is race used to make false biological predictions?
So if we consider the ethnic groups inhabiting the US and many countries abroad for that matter, we understand that they are not homogeneous in terms of their genetic features. And we know this on the basis of a lot of genetic admixture data. Now, having that said, the frequency of a certain allelic variant can vary from one ethnic group to another. And this point is nicely illustrated by the recent elucidation of APOL1 and risk of kidney disease in those of recent African ancestry. Now, for those that may not be familiar, APOL1 encodes the protein apolipoprotein 1, which lyses trypanosomes, or the organisms that cause African sleeping sickness. It's only the nephropathy or disease-associated alleles, G1 and G2, that can lyse this very resistant form of trypanosome known as Brucei rudesiense. If you are an individual living in one of these endemic areas and you carry 0 copies of this nephropathy-associated allele, then you have a high risk of succumbing to disease. 1 copy of the allele confers a heterozygous survival advantage. But if you're an individual that has 2 copies of these nephropathy-associated alleles, about 1 in 5 individuals will develop kidney disease. So there is a survival advantage against trypanosomes, but a homozygous disadvantage for the development of kidney disease. These variants account for about 70% of the non-diabetic kidney failure that we see in African Americans, and about 4 in 10 African Americans on dialysis have kidney failure that we attribute to APOL1 associated diseases. This high-risk genotype has also been described by our cardiology colleagues as being associated with early onset hypertension. In this diverse Brazilian cohort of about 318 patients with nephrotic syndrome, about 6% overall were identified as having a high-risk APOL1 genotype. Now, I'm pointing out this study because, interestingly, 47%, so almost half, of those that were identified as having a high-risk APOL1 genotype self-identified as white. So this brings up a very important example of why the social construct of race can get in the way of science and why using race as a proxy for suspected genetic diagnoses can be very misleading, getting back to what Professor Roberts was alluding to. As a pediatrician, I often share with my medical students that the first 2 patients with cystic fibrosis that I took care of as a resident were Black. And the 1 fatal rhabdomyolysis case associated with sickle cell trait that I was involved with involved a white child with sickle cell trait. So we really have to be thoughtful and careful about our tendency to place people in different diagnoses buckets on the basis of race. So as we move forward in this discussion, let's take a look at this schematic created by Dr. Norton and her colleagues, where we find interconnected mechanisms underlying associations between socioeconomic status and overall health outcomes. We appreciate here that SES factors like access to paid sick leave, housing stability, housing security, and other factors all potentially contribute to this complex and overlapping set of social determinants that interact, combine, and ultimately impact health outcomes. Underlying all of this is the consideration of how racial biases may amplify these associations. So that impact of racism, bias, and discrimination really places a chasm, if you will, between the necessary determinants of health, like economic stability. Policies like redlining have certainly impacted housing security and how tax dollars are distributed to support things like the walkability of a neighborhood, playgrounds to promote physical activity. So things all contributing to healthy lifestyle behaviors. These policies impact how taxes are distributed, that in turn impact the funding of public education, public schools, which further disenfranchises those that have been victimized by those policies. The role of allosteric load on an impact on chronic kidney disease is an area of growing study. And finally, data evaluating, building cultural competency and expanding diversity in health professions has shown that patient outcomes really do improve when there's more patient-provider racial concordance, or that is when the team members taking care of a patient more mirror the patients themselves. So this interesting study highlights how low provider awareness of racial disparities in kidney transplant, for example, particularly among staff that may have more routine contact with patients, can impact waitlisting rates. So this was a cross-sectional analysis of a survey of providers from about 655 low waitlisting dialysis facilities across all 18 ESRD networks. These data were then merged with the 2014 USRDS and US Census data. So the outcome of awareness of the national racial disparity in waitlisting was defined as responding yes to this question. Nationally, do you think that African Americans currently have lower waitlisting rates than white patients on average? They measured a secondary outcome, which included the providers' perceptions of racial differences within their racial difference in waitlisting, rather, at their own dialysis facilities. So among the 655 providers that were surveyed, only 19% were aware of a national racial disparity. 50% of medical directors were aware, only 11% of nurse managers, and only 16% of the other providers in the dialysis units were aware. And when you look here, these are the patients that probably have the most direct contact with our patients. After an analysis adjusting for provider and facility characteristics, nurse managers were 7 times as likely as medical directors to not be aware of this disparity. White providers 2.64 times more likely to be unaware than Black providers. Facilities in the South were 3 times as likely to be unaware than facilities in the Northeast. And facilities with a low percentage of Black patients were almost twice as likely to be unaware than facilities that had a high percentage of Black patients. So overall, in this survey, about 1/4 or 25% of the facilities had a more than 5% racial difference in waitlisting in their own facilities, but only 5% of them were aware. So socioeconomic status and CKD. There have been several studies that have highlighted the impact of socioeconomic status on CKD outcomes. The question really is, however, is how do we best define it? And there's a lot of debate about this. So conventional models currently use income, education, zip code data, insurance status, all as proxies for socioeconomic status, but there are clear problems with these measures. Within a given zip code, you may have several different families living with very different income levels. I grew up in Durham, North Carolina, and I'll tell you that when I drive through my hometown, it is not that uncommon for me to see a refurbished home that's now worth almost $1 million or over $1 million, completely flanked by homes that are falling apart. We have this tendency to want to interchange some of these measures. So different SES measures, we have to remember, cannot be assumed to be interchangeable. Income and education, for example. Many of you will think the moment that you completed your MD or your PhD degrees, I think we'll all agree that that was not necessarily the most financially lucrative moment of our lives. So we really have to be thoughtful with how we're using these measures. And then finally, there's the constant challenge of deciphering unmeasured socioeconomic differences when taking into account the effect of race on outcomes. So how much of the disparities we see in CKD outcomes are actually related to poverty? So Dr. Deidre Cruz, who's our current ASN secretary and an adult nephrology colleague from Hopkins, looked specifically at this question in about 2,300 adults residing in 12 neighborhoods that were selected both for socioeconomic and racial diversity in Baltimore. She defined a low socioeconomic status as a self-reported income that was below the 125th percentile of the Health and Human Services guidelines, and a high socioeconomic status as being above that 125th percentile. Overall in this study, race was not associated with chronic kidney disease, but African Americans had a much greater odds of it having advanced chronic kidney disease when it was found. Overall, low socioeconomic status was independently associated with a 59% greater odds of CKD after adjustment for demographics, insurance status, and comorbid diseases. What was interesting is that when this cohort was stratified by race, low socioeconomic status was associated with chronic kidney disease in Black patients, but not in white patients in this cohort. In transplant, we have several studies with disparate outcomes by race that cause us to consider that some of these disparities may reflect unmeasured socioeconomic differences that impacted by downstream effects of structural racism and bias. So this is a study of 8,400 pediatric patients with end-stage kidney disease from the USRDS database, and differences in overall time from diagnosis of end-stage kidney disease to transplant were evaluated. And then they grouped these individuals by age. Overall, they found no significant interaction between race and individual or even neighborhood level socioeconomic factors to transplant access. But in their multiple variable adjusted models, the rate of transplantation was clearly lower in Hispanic patients and Black patients compared to white pediatric patients. And these disparities were more prevalent in the older age group, where Black patients were had a 40% lower rate of transplantation, and Hispanic patients a 38% lower rate of transplant compared to white patients. They then looked at the effect of sequentially adjusting for socioeconomic status on transplant and found it had little to no effect on the adjusted hazard ratios. So across all types of health insurance, private, public, other, or uninsured, white pediatric patients in this cohort had higher rates of deceased donor kidney transplant, living donor kidney transplant compared to Black and Hispanic patients. And in particular in private and uninsured populations, white children had more access to deceased donor kidney transplant compared to Black and Hispanic patients. So moving to another disease process where we've seen stark differences in outcomes based on race, several researchers have examined the impact of socioeconomic status on lupus nephritis outcomes, specifically hypothesizing that patients with lower socioeconomic status would have a worse renal outcome independent of race or ethnicity. So Barr et al. Evaluated this hypothesis in about 128 consecutive patients with proliferative lupus nephritis in their urban New York centers. So almost 130 patients with very similar disease severity. This Kaplan-Meier curve displays the observation that this group had that Black and Hispanic patients experienced the endpoint of doubling of their serum creatinine statistically more often than white patients. They then created what was called a race ethnicity model, where they adjusted for age, sex, IV cyclophosphamide treatment, hypertension, and serum creatinine, but not socioeconomic measures. And they found that Black patients with this model had a 3.5 times higher risk for reaching the endpoint of doubling the serum creatinine. In Hispanic patients, 5.5 fold risk compared to white patients. After adjusting for socioeconomic factors, the magnitude of the association for Black patients was reduced and no longer statistically significant. And I apologize, the screen seems to be stuck here. And a similar pattern was seen for Hispanic patients, but the association with disease progression remained. Here we go. So with Black patients, once this model was adjusted for all those factors, the risk was attenuated, but was no longer significant. With Hispanic patients, the relative risk was attenuated, but remained significant. So the authors then went on to complete a socioeconomic model to show relative risk of progression of proliferative lupus nephritis associated with living in poverty. And they described poverty, or defined it rather, as more than 10% of the neighborhood residents living below the federal poverty line. Then they turned around and adjusted it for age, sex, IV cyclophosphamide treatment, hypertension, serum creatinine, and insurance status, but left out race and ethnicity. What they found in the study was that poor individuals were 6 times as likely to have a doubling of their serum creatinine. Once they adjusted for race or ethnicity, this association was attenuated, but still remained significant. And so adding race to this model was not enough to erase the impact of poverty on the outcome. So we've seen similar disparate findings reported across Hispanic cohorts. Now, I do want to pause here and point out that we apply the label of Hispanic broadly to a very heterogeneous group of individuals of Mexican, Puerto Rican, Cuban, Central and South American ancestry. And so it's important to keep that in mind. Now, studies particularly focusing on Texas Hispanic cohorts, which proportionally have more Amerindian ancestry likened to Hispanic patients from Mexico, and Mexican cohorts compared to Europeans have greater disease activity at presentation. They have markedly higher rates of renal involvement and greater kidney damage, accrual, and progression to end-stage kidney disease over time. Now, these findings have been replicated in several studies, but 2 that are notable to mention. The Glidell study group is an inception cohort of almost 1,400 individuals with lupus across Latin America. And the Lumina study group is a US-based multi-ethnic cohort of 630 Black, white, and Hispanic patients from UAB, University of Texas Health Science Center in Houston, and the University of Puerto Rico. So the researchers from these 2 study groups came together and they compared 115 Hispanic patients from Texas from the Lumina cohort and 613 Latin American mestizo patients from the Glidell cohort to evaluate whether Amerindian ancestry could explain outcome differences between the groups. And what they found in this study was that despite comparable genetic background, very comparable treatment, Hispanic patients living in the US had a poorer prognosis than their counterparts in Latin America. Quite astonishing. And so with this, the only thing that they were really left with is thinking about how socioeconomic factors must be playing a role to account for the residual disparities. So poverty, we know, imposes many challenges on families that may affect health behavior due to a lack of ability to advocate effectively from low health literacy. There's still a lot of distrust in the system, not just dependent on things that happened in the past, but things that continue to happen. We understand that patients that are living in our very rural areas may reside, especially in the world of pediatrics, more than 200 miles from the nearest pediatric subspecialist, which prohibits timely access to medical care. And then once they get there, they may not be able to afford the out-of-pocket costs. We looked at this closely within our institution here and found that my patients on average travel 70 miles one way to get to clinical care with us. And so that's informed our decision to create more satellite clinics out in the community. In resource poor areas, specialty medications may be prohibitively expensive or just flat out unavailable. And then environmental factors that we've alluded to before all can contribute to the biologic sequelae impacting CKD progression and outcome. Now, in pediatrics, we've not had data truly linking income as a correlate of poverty with CKD progression. But within the CKID study, and CKIDs, for those unfamiliar, is a longitudinal NIH-sponsored multi-center trial for children with various degrees of chronic kidney disease. They looked at the question of income and found that it didn't correlate with CKD progression, but interestingly, lead exposure did. So for each 1 microgram per deciliter increase in blood lead levels, there was an associated 12% decline in EGFR. So taking this a step forward, data in adults have connected the risk of lead exposure to outcomes in patients with end-stage kidney disease. So this was a very interesting study from Danziger from Harvard and a few of his colleagues in Minnesota, where they looked at patient-level data for almost 600,000 patients initiating dialysis between 2005 and 2017. And they merged this data with, from the USRDS, and then they merged this data from with the EPA Safe Drinking Water Information System. Specifically, they documented the average 90th percentile lead concentrations in community water systems during the 5 years before dialysis initiation, according to the city of residence. So not pictured here, they found that patients in cities with detectable lead levels in community water had a significantly lower pre-end-stage kidney disease hemoglobin concentration. They also found that these patients had more ESA use per unit increase in water lead levels prior to dialysis initiation. It's important to note that these associations were observed at lead levels that were far below the EPA threshold that mandates regulatory action. They additionally found that they also observed environmental inequities, finding significantly higher water lead levels and slower declines over time in Black patients compared to white patients. So here again, another example of structural bias, potentially racism, environmental factors that can have a direct impact on the care that our patients need. So as we reflect a little bit on the small snippet that I played from Dr. Roberts' TED Talk, I do encourage people to listen to the full presentation. It was very informative. She goes through many examples of how we tend to use race throughout our clinical algorithms, throughout history, and a lot of the problems associated, but not only with the origins of how it came to be, but the problems that it continues to perpetuate. So there's not a single person attending today's talk who is not aware of the growing scrutiny over the inclusion of race modifiers in different clinical algorithms, in particular for our community with EGFR estimation. This was an article that came out in 2020 that highlighted multiple areas where race has been included in our clinical algorithms, but specifically to with our community, there were efforts to help us frame and understand some of the unintentional consequences of this with race inclusion in EGFR impacting delayed referral for dialysis options and transplant, potentially decreasing the donor pool for Black kidney transplant patients. In pediatrics, we see a lot of children with congenital anomalies of the urinary tract, and their race was included in the calculator for trying to define which children were to be evaluated, were to receive diagnostic evaluations in the presence of a UTI. It's no longer included in the calculator, but had been there for many years. So I have this just case example. This was a clinical conundrum that was brought to me by one of our medicine chief residents several months ago, where he was on call and had a 65-year-old white patient with known chronic kidney disease. And by our estimation equation is GFR estimated out to 27. Well, many of you are familiar that a lot of us have this GFR cutoff of 30 that would qualify or not, or disqualify somebody from getting an MR scan. And this happened to be a gentleman that came in with an abdominal emergency, a non-contrasted CT scan, wanting to avoid contrast because of the CKD, was not going to give them the information they wanted and really wanted to get an MRI. But because his GFR was 27, he didn't qualify for it. And now if we think about this same gentleman, let's say if he were a Black male, then he would qualify to get the MR scan. So is he at less risk for nephrogenic fibrosis dermopathy? If we're talking about a nephrotoxic drug, this gentleman would get a much larger dose. So would he be at risk for more nephrotoxicity because of that? This gentleman would probably get a dose reduction. So would he be at risk of having a poor outcome because he didn't get enough drug? And so lots of clinical questions related to equity that come to mind here, all on the basis of, two people coming in with the same creatinine, and the only thing that is different is the basis of the color of their skin, with one that would be classified as stage 4, so more advanced disease, and one with less advanced disease. So Ahmed and all looked at this in 2020 in about 2,200 African Americans and found that about a third of them would have experienced a change to a more severe chronic kidney disease stage if the race multiplier were removed. In total, about 24% would be reclassified from stage 3B to stage 4. And these all have implications for kidney replacement therapy planning and referral for dialysis option education and pre-transplant evaluation. So this is a little bit of a tangent, but as a pediatrician and all my pediatric colleagues will recognize that we've never had race as a part of our estimation equations. And so we have this interesting phenomena. So if I give you a patient who is 17 years, 364 days old with a creatinine of 1.5, their estimated GFR is 51. As soon as they turn 18, and they go into an adult clinic, on the basis of our previous formula, their GFR could have been 78 or it could have been 67. These are all very different numbers. Now, thankfully, when my patients leave my pediatric clinic and they visit my fellow Tar Heel adult colleague, Dr. Paparello, they will only have to have a conversation about one of those differences. So in response to the national call to evaluate the use of race in EGFR estimation, the National Kidney Foundation and the American Society of Nephrology developed a joint task force that looked at this question over a 10-month extensive process. And they developed a unifying approach for estimating GFR that excludes race. So they identified 26 different approaches that did and did not include race. They narrowed the focus by consensus down to 5, and then they evaluated each approach on 6 different characteristics: assay availability and standardization, implementation, population diversity and equation development, the performance compared with measured GFR, consider the consequences to clinical care, population tracking and research, and then very importantly, patient-centeredness. So they recommended the immediate implementation of the CKD epi-creatinine equation that was refitted without the race variable in all laboratories in the US. Now, understanding that this is the initial phase of what has been recommended, ultimately we want to move to other markers that may be provide a little more precision, but it's going to be a much larger lift. And certainly we need to be thoughtful about the research to help us understand our impact in this arena. So the CKD EPI 2021 creatinine formula is a refitted equation. There was a lot of diversity in its development, and it has acceptable performance characteristics similar to previous equations, but now without the potential consequences of disproportionately affecting any one group of individuals. Now, were many of the disparities that we've talked about today present before we had race modifiers in these equations? Yes, of course. Will the removal of the race modifier in EGFR estimation eliminate these disparities? No. But what this effort does accomplish is to eliminate the unintentional additive impact of the disparities we see and move our community to be more intentional about considering race as the social construct that it truly is, rather than perpetuating myths of true biological differences. We're in exciting times. You know, one of the most important pieces of legislation to impact the care of our patients was passed just 2 years ago, the Advancing American Kidney Health Initiative. There are lofty goals here for us to reduce the number of Americans developing end-stage kidney disease by 25% by 2030. We want to move our patients from in-center hemodialysis to therapies at home, including home dialysis and transplant. And we want to do some of this by increasing the pool of kidneys available for transplantation. So we have attention, we have government partners, we have dollars behind this effort. What will help us to fail is if we don't address the disparities that we see before our eyes. So this is a schematic from Dr. Norris in 2008 to help us really think about what we're truly seeing when we're looking at these race-based outcome differences, what's truly accounting for it. And truly, this component, the biologic component, is quite small. The majority of this difference that we're seeing can be explained by social-based health disparities and healthcare disparities. So how do we do better? Well, the good news is that education seems to help. There's been a marked improvement in CKD and end-stage kidney disease metrics for, I'm going to highlight African Americans right now over time, with continuing reduction in the level of racial and ethnic disparities for multiple CKD metrics. So when we look at how well are we paying attention to urinary albumin in patients with diabetes, certainly we've made improvements there. Are patients with diabetes getting better care? We're paying attention to eye exams, lipid exams. Yes, we're making improvements there, all with education. Are these patients on ACE inhibitors? And I need to put in another imaginary line here. Are they on SGLT2 inhibitors? I hope that we'll see a similar trend of increase. All of these things have helped to aid this decreased incidence of end-stage kidney disease per million population and decrease in mortality. As you can see, we still have quite a bit of work to do when we focus in on transplant. So to be clear, I am not advocating that we ignore race. We can't do that. If we do so, it will blind us to the impact that racism has on society. We just really need to be thoughtful about these tools that we're using that use race as risk predictors, and understand that we run the risk of interpreting racial disparities as fixed facts versus injustices that require and have the opportunity for us to intervene. And then finally, we have to recognize that there's no such thing as a homogeneous race. People self-define their race in different ways, and many people are of mixed race, which makes any single category flawed. So not only do we have to try to not be racist in our care and thinking about these structural barriers, we have to be anti-racist. Actively, we need to make sure that research that is focused on race-based health disparities is held at a higher standard. We need to discourage studies that are looking at race as a biologic factor and not going the extra step to acknowledge and study the downstream effects of structural racism and patient outcomes. And to do this well, we need to invite and integrate the expertise of social scientists in these studies that we are completing. We need to be thoughtful about interrogating our kidney health algorithms and policies that include race, interrogate the validity, the potential consequences of perpetuating disparities. These are clearly largely unintended, but just because it's unintended doesn't mean that it's not there. We really need to support policies that help to enhance our pipelines to increase the diverse workforce. And we need to think about this in its totality and support the contributions, for example, of our international medical graduates. All of these are initiatives that need to be championed. And then finally, all of us that are in healthcare, we have to recognize that innate to our careers, as we stepped into these fields, we immediately became leaders. Whether that's what you asked for or not, we immediately became leaders. And so we have to use that privilege to advocate for policies that address social and structural factors like transportation, housing security, food insecurity. As we're pushing the expansion of telemedicine, we've got to pay attention to the digital divide that still persists. and think about our school funding. All of these are things that we have to care about. As I come to a close, I'm gonna put in a shameless plug. You are in the presence of our fearless leader, but if you haven't taken a moment to go to forkidneyhealth.org and learn how you can become a part of our community to push forward these 4 initiatives to intervene earlier, transform transplant, accelerate innovation, and achieve equity, I invite you to do so. And with that, I will close and open that screen. And I think that we have a few minutes for question and answers.
Thank you so much, Dr. Gibson, for an outstanding presentation and really eye-opening, for our community. So we'll start with some questions that we have in the chat box. So a question from Dr. Quaggen, who is commenting, what a fantastic seminar. NIH has said they are going to fund research to decrease health disparities in the kidney community where there are so many disparities. What do you think is the most important priority?
Oh, that is a really great question. I appreciate that question. I think that there is definitely some low-hanging fruit that's there, with the data that I just went through for EGFR estimation. We can't just stop with the recommendation. We really need funding to help us make sure that we're measuring what we've decided to do. Is it making a difference? We need more biomarkers. We need to help, our community understand how to be able to utilize these new things in an equitable manner. So that's one thing. I do think that we need more support of sort of the social science aspect. Many of us that are on the clinical side of things, on the bench, basic science side of things, we have best intentions when we're designing studies, but we really need to bring in the social scientists to really help us understand these other overlapping issues that clearly impact the outcomes that we're seeing. So I do think that there needs to be more of an appreciation of the types of science that's out there, and make sure that we're maximally supporting it all.
Great. We have a question from Arnold Davis. So Mr. Davis is asking, what else can be done to create a more diverse nephrology workforce?
Yeah, so many different points. This is an area that I'm actually quite passionate about. So the pipeline starts early. I think that if you are just looking at your residents and trying to help them understand why nephrology is the best career ever to choose, we're missing the boat. They're already differentiated. You want them when they're undifferentiated stem cells to help them with that exposure. Yes, medical student level, but yes, we've got to reach back to our colleges. Yes, we've got to reach back to high school. Yes, even elementary school. Because when we look at the populations right now that are underrepresented in nephrology, the intervention has to happen at that point in time to make sure that they have the opportunity to get the exposure, to get the education, to get the experience that they need to be competitive, to get into medical school and to be successful, and then go on from there. So I'm very passionate about that. We need to be a little more creative in what training looks like. So I have the privilege right now with my ASM role of working with our workforce training committee and interacting with the ABIM and the ACGME to think about how do we revamp training and make it more, I won't say palatable, but to make it more enticing for our trainees. I think that people are really wanting a little more diversity in what they're able to do. And this sort of idea of one size fits all is not helping us. And so I think that we have to think as a community, how do we best attract trainees into our field by providing them more opportunities to differentiate the type of careers that they really want. And then we have to recognize that these are all people, they've got to live. So all of these, the efforts that we're looking at in terms of reimbursement, how expensive it is to try to even become a doctor. And then you're looking at careers that may not have the same return on investment that, say, some of these other higher paying fields have. How do we bridge that divide? We've tried to address, some of this with the ASN loan mitigation program for underrepresented minorities. But I think that we need a lot more creative solutions along those lines to really try to grow our workforce.
That's a really great points. We have one question in the Q&A. Such an important and wonderful talk. If there is time, could you expand on how we might address racial disparities while avoiding essentializing race education, study design, etc.?
I'm gonna get that. Can I get that question one more time?
So how we might address racial disparities while at the same time we avoid essentializing race in education and study design?
Yeah, no, I think it's a great question. I think with education in particular, the more that we can be intentional with our education and highlighting race as a social construct, as we're talking to patients, again, we can't avoid it. And I know that there's a little bit of angst of us promoting race essentialism if we continue to draw these associations between race and certain diagnoses and treatment response patterns and what have you. But if those words are coming out of your mouth that, we see a higher proportion of X in Black patients or a higher proportion of X in Hispanic or Asian patients, that needs to be followed up very quickly with, we understand that race is a social construct. And so we need to think what other things could be impacting, these outcomes that we're seeing. So it's not that you turn a blind eye. I think that we have to point it out. We have to include it. But we just need to make certain that we're not ignoring the impact of these other factors.
We have another question from Dr. Quaggen. The data on risk progression of Hispanic patients in Latin America versus US is really striking. If we are to make an impact, do we really need to rethink our entire healthcare system in this country? A tough question. I couldn't agree more. So.
That is a very tough question, but clearly our system is still broken. We're talking about our Hispanic population. We understand that for some, the barrier is a lack of being a documented citizen and having access to healthcare based upon the structure we have in place. Despite the contributions from that community, $7 billion of taxes generated and contributed from that community, they don't have access to receive any of the benefits from that contribution. So I really do think that we absolutely need to think about how to make that better. How do we extend access? Is it universal healthcare for all? I don't know, but we clearly understand that what we have right now is not working for a lot of the people that we have a responsibility and obligation to care for in this country.
Definitely, and with the great data that you showed on the pediatric populations as well. I mean, what do you think, maybe in terms of priorities and restructuring the healthcare system, could the pediatric population be the priority to target, and any thoughts and hopefully any plans that you are aware of?
No, absolutely. So, I think as a pediatrician, and I'm sure a lot of my colleagues will agree, we look at one of our responsibilities as trying to transition the patients that we care for in the best state of health possible. When they go into adults, these young patients are going to become adults with chronic disease. And to do that, they have to have access to healthcare. Now, I will say, and this can be very state dependent, right, that there are a lot of areas where healthcare for children is prioritized. And Medicaid has been a godsend for a lot of our patients to help bridge that. But it's not the same in every state, number one. And then number two, we have this, in addition to pediatrics, we have this other very vulnerable group of individuals called young adults, between the ages of 18 and 30 that, may not easily qualify for health insurance, and certainly not public health insurance as things are currently structured. And that's another critical time where we see a lot of these disparate outcomes, and increased mortality is not all driven by low health literacy. A lot of it has to do with access to care. So I do think that in terms of priorities, yes, we need to provide a little more equity when it comes to sort of the increased access to care for children. We also really need to pay attention to our young adults.
Definitely. And we have one last question from Dr. Tarpey, who is asking, where do you see opportunities for industry to be an ally in making progress on and resolving the issues you have highlighted?
Mm-hmm. I am so appreciative to our industry partners. There's a lot of progress that we're making because of the relationships that our science community has with our industry partners. We need more. We need to continue our push for drug development. I live in the space of rare diseases. We need to be thoughtful of how do we bridge the gap of access to these wonderful new therapeutics that we have. Coming together to figure out cost and trying to prevent that from being a barrier for our patients. As a pediatrician, I need our children included in clinical trials. So I have volunteered to be a PI on several adult studies just so I could be at the table and talk to our industry partners to say, you know what, a lot of, about 20% of patients with lupus actually had disease onset as a child and have a lot of children that need access to these medications, but we need the data. Please include them. I'm here to help you. And I've been very appreciative of sort of the growing willingness to do that. We need to think about how, you can have the medication, so cost is one thing. Delivery is another. I think that the world of diabetes has been very revolutionary in helping patients be more adherent to therapies, once weekly injections and pods and pods that prevent you from having to inject yourself every day. Our kidney patients, transplant patients, maybe taking 13, 20 pills multiple times a day. And so thinking about drug delivery, that's another area that I would love to see us make some forward progress. So lots of opportunities there. We're very appreciative of our industry partners, and we really need to continue to support.
Excellent. Thank you so much, Dr. Gibson, for an excellent seminar, answering, great questions. And thank you so much all for joining us for, this great activity of the NUGo Symposium. Just, wanted to remind you to check our Nephro Hub for updates from our center. There is also a call for pilot and feasibility grants, and you can see in the chat box, links on the Instagram and Twitter. Again, thank you so much, and you have a great day.